Welcome to NCLEX RN Review, produced by Nursing Tutorial and Consulting Services. This session is on gastrointestinal. I'm Judith Miller, and I will be your guide as we discuss gastrointestinal issues. We're going to start right off with a question. An upper GI series is ordered for a client. Which action is essential for the nurse to take? 1. Assess for an allergy to shellfish. 2. Instruct the client to have nothing to eat after midnight the night before the test. 3. Encourage the client to drink plenty of liquids the day of the test. Or 4. Tell the client not to eat any foods containing fat for 18 hours before the test. And the correct answer is number 2. Prior to an upper GI series, the preparation is simply NPO. Now let's take a look at some of those other choices. 1 said assess for an allergy to shellfish. Upper GI series uses barium. It does not use iodine. Barium is not iodine, so we don't have to ask the iodine question. Now, tell me if you can think of any tests in which you would need to have the client drink plenty of fluids before the test. Now, that's right. Some of you are saying about a sonogram, a pelvic sonogram, in non-pregnant or early pregnant individuals. That's true. But you don't drink plenty of fluids with an upper GI series. Now, as far as fat restriction, that is more likely related to someone who is going to have gallbladder x-rays. Let's do another question. The client had a barium enema. Following the barium enema, the nurse should anticipate an order for 1. An antacid, 2. A laxative, 3. A muscle relaxant, or 4. A sedative. And the correct answer is a laxative. We want to be able to get rid of that barium that was put in during the barium enema. Another question they sometimes ask about a barium enema is the fact that during the procedure the patient needs to turn from side to side as they fill the bowel up with barium and take x-rays. So let's take a look at the GI diagnostic tests and just summarize the preparation for and any special care afterwards if there is. A barium swallow, otherwise called an upper GI series. We just had a question about that, and it's NPO. Now, they might also need a laxative after the procedure because they've swallowed barium and it has to work its way completely through the GI tract. Now, an EGD, esophago-gastroduodenoscopy. Some people call this gastroscopy. Other people call it endoscopy. Whatever term is used, they're sticking a scope down, looking at the esophagus, the stomach, and the very top of the duodenum. The preparation for this is quite simple, NPO. Now, afterwards, we need to make sure that the gag reflex has returned. Usually, they are going to use some lidocaine spray to deaden the gag reflex before they pass the tube. And afterwards, you need to make sure that gag reflex is returned. And that could be anywhere from a few minutes, 10, 15 minutes, to not more than an hour or 2, depending on the preparation used. They usually will use conscious sedation for this patient. So you'd want to monitor vital signs until they were fully recovered from the conscious sedation. Now, if we take a look at sigmoidoscopy, and this, we're at the other end of the GI tract, and a sigmoidoscopy, the scope goes in just to the sigmoid colon, the lower end of the bowel, and the preparation for that is quite simple. An enema, usually one of the packaged enemas, about an hour before the procedure. Now, if we take a look at a colonoscopy, this scope goes all the way up, so it goes in through the rectum and goes up the descending colon, across the transverse colon, and then down the ascending colon. The preparation for this is a full bowel prep. So that means that they're going to be getting a laxative, usually either something like a phosphorus soda preparation, or sometimes we'll have Go Lightly, which is the powder in the big plastic jug, and they add water to that. But it's going to be a laxative preparation and a clear liquid diet the day before the procedure. And usually we recommend to them that their clear liquids not be any red liquids. The reason for that, when the doctor is looking through the scope, if there happened to be any red jello juice in there, it might look to the physician like it was blood. And it's pretty hard to tell the difference between red jello juice and blood when you're looking through a scope. But if you had a little bit of green jello juice, you'd know it's not blood. So we usually just tell them no red liquids in preparation for the colonoscopy. Now, if we talk about a barium enema, the preparation for that is quite similar to that of a colonoscopy. So for a barium enema, it's going to be the bowel prep and clear liquids the day before the procedure, and then again NPO the night before. We don't care what color your clear liquids are for a barium enema, because this is x-rays and they're in black and white, so it really doesn't matter what color they are. Another test I want us to talk about, and one we know has been on the exam, is a liver biopsy. Now, the liver is a very busy organ. Among other things, it makes prothrombin, a clotting factor. They would not do a liver biopsy unless they suspected some type of liver disease. And before a liver biopsy can be done, before you puncture one of the most vascular organs in the body, we want to make sure that the blood has enough clotting ability so the patient won't hemorrhage. So they're going to be doing a prothrombin time and clotting studies to make sure that it's safe to do this liver biopsy. Now, they've also asked questions about positioning of the patient during and after the biopsy. Since the liver is on the right side of the body, during the biopsy they're going to be on the left side. So the liver is exposed and the doctor can insert the needle and do the biopsy. After the biopsy, we turn the patient on their right side to put pressure on the site and stop the bleeding. So left side during the biopsy, right side after the biopsy. They might also do liver function tests, which are a series of blood tests, including bilirubin levels and then all the transaminase studies, as well as maybe a CPK and an alkaline phosphatase. Now, another test they've asked about on the exam has been paracentesis. This is done for the patient who has ascites. So if they have an abdomen full of ascites fluids, usually patients with liver disease, the physician will insert a needle and withdraw the ascites fluid, either for diagnosis or simply to relieve the pressure in the abdominal cavity. The thing you must do before they do that is to have the patient empty their bladder. You don't want the physician accidentally puncturing the bladder and removing urine instead of ascites fluid. So have the patient void or empty their bladder before the procedure. And we want to talk about a few common procedures. I want to talk about enemas. Cleansing enemas, as you recall, are large volume enemas. So these are 500 to 1,000 milliliters of a substance like saline or tap water or soap suds. An oil retention enema is a much smaller enema, more like 5 or 6 ounces, 150 to 200 milliliters. And it's a retention enema to soften feces. Let's look at a question. An oil retention enema and a cleansing enema are ordered for a client. How should the nurse administer these? Number 1, administer the cleansing enema followed by the oil retention enema. Number 2, administer the oil retention enema and then the cleansing enema. 3, administer the cleansing enema today and the oil retention enema tomorrow. 4, question the order as 2 enemas should not be given together. Well, that's what I call a head spinner of a question. Now, the correct answer is number 2. And it would probably help to understand this if I were to tell you that the patient that needs this combination of enemas is probably one who has a fecal impaction. The oil retention enema is given to soften the feces, and then the cleansing enema to get rid of them. And we certainly hope this works, because if this does not work, the next step is probably going to be a manual extraction or manual removal of feces, which neither the nurse nor the patient like. I want us to look at another procedure, if you will, associated with the GI tract, and that's nasogastric intubation. Now, when we talk about passing a tube, I know you know how to measure the tube. It goes tip of nose, earlobe to xiphoid process. You position the patient in a high Fowler's position, so they're going to be sitting up. Now, as you start to pass the tube and you go back through the nasopharynx, they can tilt their head back. But as you get to the oropharynx, you want them to bend forward. So they need to flex their head, bend forward, and swallow. So you'll have a glass of water with a straw, and you'll tell them, swallow, swallow, swallow. Now, the reason for doing this, as they swallow, that will tend to help the tube to move down and go down the esophagus rather than going down the trachea. And when they bend forward, they tend to close off the trachea. So have them bend forward and swallow as you pass that NG tube. Now, they might ask you questions about how to test for placement of the tube. You want to make sure that that tube is down the esophagus into the stomach where it's supposed to be. And the correct answer would be to aspirate the contents and check the pH. So aspirate contents and check pH. The pH should be less than 4. Once in a while a hospital will say 5, but most places will tell you 4. That's quite acid, and it should be quite acid. The pH of the stomach is normally something like 1 or 2. So a pH of less than 4 usually considers that it's in the stomach. This is much better than the technique of injecting air and listening. When you inject air and listen for that swoosh, that thump with your stethoscope, all that tells you is it's somewhere in the tract. But it could be in the base, and it could be in the esophagus, and you could still hear that air coming through. You want that tube down into the stomach far enough that you can suck out the fluid. So aspirating the contents and checking the pH is by far the best way to assess placement of a tube. Now, sometimes we could x-ray. We don't do that for every patient, but if you had an unconscious patient who doesn't have a gag coughing reflex, where you wouldn't have a clue whether you were in the right track or not, they might x-ray the patient, but that's not routinely done. That would tell you for sure, but we don't routinely do that. There are tubes that go down through the nose into the small intestine. These tubes are about 10 feet long. They are used in people who have intestinal obstruction. They are tubes such as the Cantor tube and the Miller-Abbott tube. We have single lube, 1 name, 1 lumen, 2 names, 2 lumens, so Miller-Abbott is a double lumen. These are weighted tubes. They are usually passed by the physician. So the physician passes this tube through the nose, down into the stomach. That's as far as they can pass the tube. They then go out of the stomach into the small intestine through the combination of gravity and peristalsis. So if we turn the patient onto their right side, that will help it move out the pyloric sphincter and into the duodenum and on through the rest of the small bowel. So they might ask you a question about turning the patient on their right side immediately after passage of a naso-intestinal tube. Sometimes they go on further and ask you then move to the left side, then move to the right side. So they ask you to go from side to side. But by far the most important turning is that first one, where we put them onto their right side for that first hour after the tube is passed. Now for a question. An adult is admitted with an intestinal obstruction. Immediately following passage of a naso-intestinal tube by the physician, the nurse enters the room and notes the proximal end of the tube is lying next to the client's head and is not taped to the face. What should the nurse do? Number 1, tape the tube to the client's nose and face. Number 2, ask the client if the tube is comfortable. Choice 3, leave the tube coiled beside the client's head. Choice 4, aspirate and check for gastric contents before taping. So picture this. The tube is now coiled next to the patient's head, and it's not taped to the face. So what do? Leave it alone. Simply leave the tube there, because remember, the physician passed this tube only as far as the stomach. In order for it to pass out and go into the small intestine where it needs to be, you've got to have the tube free to move. So if you tape the tube to the face, it's not going anywhere. So you'd have to eliminate any answer that had you tape the tube to the face. Now, one of the choices that you had was to ask the patient if the tube is comfortable. No patient with a tube down their nose is comfortable. So that question is meaningless. It gives you absolutely no information. That would not be a good answer to choose. Simply leave the tube coiled beside the patient's head until it reaches its destination. Once X-ray is confirmed it's at the point of the obstruction where you want it to be, then the tube can be taped so it will stay right where you want it to be. Another question for us. A 67-year-old adult has been vomiting for several days. She is admitted to the hospital where a nasogastric tube is inserted and attached to drainage. She is disoriented and has muscle weakness. Her respirations are 14 and shallow. The nurse should question which of these orders. Number 1, NPO with ice chips. 2, D5 1000 in 8 hours. 3, NG tube to suction. Or 4, intake and output. Now this is a bit tough, so let's look at the data in the question. She's been vomiting for days. She has an NG tube. She's disoriented, muscle weakness with respirations of 14 and shallow. So what does this suggest to us? Possibly it suggests to you that she might be dehydrated. Now, the disorientation suggests that she may have hyponatremia, and the muscle weakness suggests that she may have hypokalemia, so she has a sodium and potassium imbalance as well. So now if we look at those answer choices, NPO with ice chips. Now, you know if you give too many ice chips, it could cause an electrolyte imbalance. But who is responsible for how many ice chips you give? You are. You don't call the doctor and say, Doctor, sir, or ma'am, I don't think I should give so many ice chips. You have the control of how many ice chips to give. So you give only a few, just enough to keep the mouth moist, because they have dry mouths. They're mouth breathers. All right, so number 1 isn't a good answer. Now, take a look at that choice of IV. D5W, dextrose 5% in water, 1,000 milliliters in 8 hours. And we just said this patient is probably hyponatremic and hypokalemic. This is not an appropriate IV. The patient needs electrolytes, and this is just sugar water. Now, can you change the IV order on your own? No. That's like a medicine. This requires a physician's order. So the one that you would question is number 2, the D5 1000 in 8 hours. This question really required you to think and to use your information about fluid and electrolyte balance and apply it. This is a wonderful question, kind of like what NCLEX is going to give you. There's a couple other concepts I wanted us to look at, and enteral nutrition is one of these. Enteral means that the nutrients are absorbed by the GI tract. Now, most of us have oral enteral nutrition several times a day. We eat, and that's always our first choice. Now, some patients are not able to swallow. Maybe they've had a stroke, maybe they're not fully alert, and they're not able to swallow, but their intestinal tract works fine. So these would be good candidates for tube feedings. Tube feedings, when given on the short term, we can simply use an NG tube. But if they're going to be given for the long term, there'll probably be a tube inserted surgically into either the stomach, a gastrostomy, or into the small bowel, some type of enterostomy, such as a jejunostomy possibly. The tube feedings can be given either continuously, on a continuous drip, or intermittently. So usually that would be 4 times a day, maybe 400 milliliters 4 times a day, and you take a half an hour to give each 400 milliliter feeding. They could ask you a question about checking tube placement for tube feedings, and once again the answer would be to aspirate contents and check the pH. Now, what would you do if you pull out fluid? You're going to push it back, so you're not going to remove what you pull out to aspirate and check. Let's say that you are doing a check before you do an intermittent feeding, and you know that there's 350 milliliters of the previous feeding still left in the stomach. Would you give the next feeding? Of course not. Of course not. So you would note that, you would put it back, but you would not give the next feeding. And I don't need to tell you to put the head of the bed up so they're not going to aspirate. Now, suppose a patient is not able to absorb nutrients through the intestinal tract. Maybe they have a cancer in the GI tract. These would be patients that would be candidates for total parenteral nutrition, or TPN. So we're giving high concentrations of glucose and usually also amino acids, which are the building blocks of protein, and sometimes lipids or fats. And we're going to give these into a central line so that they get dumped essentially into the right atrium. Now I want you to think for a moment. If you were to give a 25–30% glucose solution in a peripheral vein, that would raise the osmotic pressure so much it would suck fluid into it and put the patient into circulatory overload very quickly. So we can't give that high a glucose concentration in a peripheral vein. So what we learned back in around 1970 or so was that if you put it into a central line, dumped it into the right atrium, it would get rapidly diluted and you could safely give hypertonic solutions. So this is total parenteral nutrition. People that get this are usually people that cannot absorb their nutrients through the intestinal tract. Another group of people that might get this would be severely burned patients who had so many caloric and protein needs that they couldn't meet it through the food that they were taking in. Anybody that's getting TPN, it's going to be on a pump, so the rate is always controlled. You need to do glucose checks, because if you put that high a concentration of glucose into the central circulation, sometimes the pancreas doesn't keep up with insulin, and we may need to add insulin to the patient. Infection control is a biggie because this is a central line. And when we talked about central lines in the Essential Concepts tape, we talked about checking, changing the dressing usually 3 times a week. We don't piggyback anything onto TPN. If you have a multi-lumen catheter, nothing else goes into the feeding line other than your TPN solution. Another concept I want us to talk about is one of nausea and vomiting. Now, if a patient has nausea and vomiting, what are some of the key things for us to look at? Fluid and electrolyte balance. So they stand the risk of getting dehydrated, hyponatremic, hypokalemic. Usually, we restrict fluids when they have nausea and vomiting, make them NPO, and then start with clear liquids and progress the diet. They could ask you a question about aspiration. This could be a big issue, particularly in a patient who is not terribly alert. Now, antiemetics. When we think about this group of drugs, all of these drugs are central nervous system depressants. So antiemetics act on the brain. They act on the vomiting center in the brain. They're CNS depressants. That means that we have a couple of side effects to observe for. One, because they're CNS depressants, they can make you sleepy. So safety issues relating to drowsiness, sleepiness, ambulation, the whole safety issue there. Driving would be a major safety issue. In addition to that, many of these drugs can drop the blood pressure rather dramatically, so we need to be concerned about orthostatic hypotension. So monitor the vital signs for patients receiving antiemetics. Now I want us to take a little look at the diet, at the clear liquid diet that we'd start this patient on. Clear liquids are just that. It's sometimes called a see-through diet. These are liquids you can see through. So black tea. Now if you put milk in the tea, it's no longer a clear liquid. Broth, sometimes called consommé. Bouillon might be another term they would use to describe broth. It's a clear soup. Apple juice. We might also allow cranberry juice. But juices like orange juice and pineapple juice have too much pulp in them, so they're not considered clear liquids. But apple juice and cranberry juice are a clear liquid. We might also have clear drinks like, say, ginger ale or 7-Up type drinks. Flavored gelatin. Now that's Jell-O, folks, without any fruit in it, just plain Jell-O. On the exam, they're going to use the terminology flavored gelatin because Jell-O is a trade name. Now, once patients are tolerating a clear liquid diet, we're then going to move them to a full liquid diet. The full liquid diet is a clear liquid diet, everything on the clear liquid, plus we now add milk products. So they can now put milk in their tea. They can now have ice cream, cream soups, fruit juices such as the orange juice and pineapple juice, and cooked cereals such as cream of wheat. Once they're tolerating that, we might move them to a soft diet, which is everything on the full liquid diet plus pureed foods, soft squishy stuff. Pureed foods, cooked fruit like applesauce, tender meat, potatoes but not fried potatoes, eggs but not fried eggs because those are too hard to digest. Now a bland diet is a soft diet without spices. So they might ask you about a bland diet as well. Soft diet but no spices. Let's look at a question. A clear liquid diet is ordered for a client. All of the following are on the tray. Which should be removed? Flavored gelatin, ice cream, beef broth, or ginger ale? And of course the answer is number 2, ice cream, because that is not a clear liquid. I have another question for you. Which client is most likely to have a clear liquid diet ordered? 1, an adult who had abdominal surgery yesterday. 2, an adult who had an open reduction of a fractured tibia yesterday. 3, a 4-year-old who is in sickle cell crisis. Or 4, a 6-year-old who has pneumonia. And the one most likely to need a clear liquid diet is number 1, the one who had abdominal surgery yesterday. With abdominal surgery, you usually have a loss of peristalsis. and until bowel sounds return, this patient would be on a clear liquid diet. The other patients are not likely to need a clear liquid diet. Now let's look at another problem in the GI tract, and this is diarrhea. I don't think I need to define that, but when a patient has frequent loose stools, we are concerned about fluid and electrolyte balance. So assessing that status would be appropriate. Usually the diet for this patient would be a clear liquid diet, and then we may move into low residue foods. We usually avoid milk in these patients, not because milk leaves so much residue, because it doesn't, but many patients, particularly adults, have some degree of lactose intolerance. And if you give them milk, they may get gassy and diarrhea from the milk, so we want to avoid that possibility completely. There are more people that have lactose intolerance than admit it, because most people don't want to give up ice cream, so they won't admit that that's what gives them the tummy ache with that. Now, skincare, obviously, in the appropriate area. Antidiarrheals. We need to think about these a moment. Some of your antidiarrheals are opiate-based. Drugs like paregoric and Lamotil have an opiate or narcotic base. In America, you know, opiate drugs are prescription only. Now, a drug like paregoric, there might be an order that would say 1 teaspoon after each loose BM. Carefully note how many teaspoons you're giving this patient, because you could depress the respiration. So monitor respirations in these patients that are getting narcotic-based antidiarrheals. If the patient is getting an antidiarrheal that contains bismuth, such as a product like Pepto-Bismol, for instance, note that bismuth turns the stools black. And if they take the chew tablets, for instance, they'll get a black tongue. So if a patient is taking bismuth and has a black tongue, it's perfectly normal response to bismuth, because that's what it does. Now, the opposite problem is constipation. And when I think about preventing constipation, I think of fluid, fiber, activity, and opportunity. Now, fluid and fiber make perfectly good sense to you, I'm sure. Activity promotes peristalsis, so I'm sure that makes good sense to you. Now, what do I mean by opportunity? I mean two things. One is heed the call. Go when you need to go, and teach your patients to do that. By ignoring the call, you're more apt to cause constipation. The other thing is recognizing when a patient is most likely to be able to move their bowels. So let's say you were trying to bowel train a patient. When would you take them to the bathroom? Right after a meal. There's something called the gastrocolic reflex, which says that every time you put something in your mouth, it causes peristalsis all the way down. And if you don't believe it, think about a baby. You give a baby a bottle, and what comes out the other end? Yes, the last bottle. If you have small children, you sit down to the dinner table, you can't get through a meal, but at least one child gets up and goes to the bathroom. And they're not trying to be difficult. They simply are obeying that gastrocolic reflex. They are taking advantage of the opportunity. Laxatives can be used to treat constipation. There are a couple times you'd never give laxatives. So if someone had right lower quadrant pain and said, please, please give me a laxative, would you do it? No. Because that right lower quadrant pain is symptomatic of appendicitis. You give a laxative to someone with appendicitis or an intestinal obstruction, and you could get perforation and rupture. Now, there are a number of kinds of laxatives. Bulk forming are very gentle. These are things that contain psyllium, P-S-Y-L-L-I-U-M, things like Metamucil, Fibricon. These just add bulk to the stool and are rather gentle and natural. Emollients soften the stools. These are things like collays. Now, that's where gentle ends. When we start talking hyperosmolar laxatives, such as milk of magnesia, go lightly. What these do is raise the osmotic pressure, pull the fluid, and then you get evacuation of stools. Now, milk of magnesia has been defined as mom, the true blue friend. The television ads try to make you think how gentle it is. But if you were to give that to someone, they probably wouldn't tell you how gentle it was. Stimulants are not gentle. Stimulants like castor oil and Dulcolax actually stimulate rather vigorous peristalsis, but they're very effective at emptying the bowel.